Why is that?
So this whole cost avoidance concept, I think, is quite important. So I used to weigh about 70 pounds more than I do now. And why? Well, at the age of 40, my clinician said, you know, it looks like you're going to get, you know, kind of adult onset diabetes, hypertension, bad stuff, change your lifestyle. Well, if I would have had my genome tested when I was early and it said, hey, here are some risk factors you're going to need to think about later in life, I would have become a vegan much sooner than I did. And therefore, you think if we spend $1,000 or whatever the price is, and then avoid heart disease, diabetes, and these things that are lifestyle diseases, as a system, our healthcare system may benefit.
Next question.
Mike Cariaso with Bioteam and Synpedia. Looking into some of this data, I've become rather skeptical of the predictive medicine. I've heard that spoken to. But it does look as though very often it's possible to predict dangerous drug interactions very early. And it seems like an area in which the standard of care may quickly, I guess the lawyers come in and force that to become done much more widely. I'm curious for the panel's views as how that might be a route towards more wide adoption.
Phil?
Well, I've been thinking about that a lot, particularly the story on warfarin, for example, and a lot of new information about the drugs that are primarily used in the psychiatric community. You would think we would have enough information now to drive it forward, but coming back to some of the points raised here, the individual and costs of the tests are still high. That's one. And two, the expert clinicians take warfarin and the genetic load. They are saying, we don't need the genotype information. Our phenotype information is good enough. There's not enough value added. So, you know, it's just going to be a hard sell. I don't think we have the killer app there yet. I'd like to see it.
I'd like to add to that. I think genetic testing is also, for PGX, it's also fundamentally disrupted to the clinical workflow. And so if you have to order a test before you write the prescription, then wait for 2 weeks, it's not going to catch. And I think that's what you've seen with the P450 Roche Ampla chip with respect to metabolism. And so, but I do think that full integration of your genome into your EMR and a web services point of care interp for the PGX that's linked to the pharmacy. You know, you're starting to see these paradigms evolve that are...
And what's that time frame?
Well, again, you know, this is moving really fast.
50 million Americans don't have health insurance.
Jorge, are you delivering information on drug interactions to your clients?
Yeah, it's a good question. So yeah, we do a full pharmacogenomic profile what we can do based on some of the limitations we have with IP and things around that nature. But what we do find is that's one of the most engaging things that we provide individuals, because you know you are able to show them everything, at least we know right now, without having to do individual tests. And so even if it's things that they're not currently taking, whether it's psychiatric medicines or things of that nature, it does engage them very quickly, because it's the actionability of that is very obvious, or at least the applicability of that is very obvious to them.
Please.
Yes, as we move into the use of electronic health records, it seems like there's an opportunity for more uniformity in terms of descriptions and phenotype descriptions. But it seems like we're still kind of hamstrung by this kind of reimbursement-based coding. And you know, it really reflects on the entire healthcare system. I mean, if we don't have a single-payer healthcare, and you know, there's the problems both in terms of individuals' liability of their genome being known by the insurance companies, and then there's the recording issue of how people get reimbursed and use incorrect codes based on reimbursement. As you speak to work with President Obama, are you addressing these issues, and what can we look forward to?
So Bush appointed me as the person responsible for all medical data in the United States 3 years ago, and I'm now continuing that role in the Obama administration. There's a difference between what the Bush administration did and what the Obama administration is doing. The Bush administration said, we're going to come up with a set of voluntary standards, and we'll build a certification body. You know, adopt these if you'd like, you'll get a good housekeeping seal. The difference with the Obama administration is it's regulation. And so we have until December 31st of this year to complete the required code sets and vocabularies that must be used by regulation if there's going to be reimbursement from Medicare and Medicaid, 50% of the healthcare dollar in this country. So yes, you'll see some very aggressive work. SNOMED CT and LOINC are the two vocabularies that will very likely be used for clinical observations, test results, both numeric and non-numeric, and that by December will be regulation.
So I don't claim to be an expert on patent law, but how is this the ability to generate whole genome sequence and look at all SNPs and all variations going to be dealt with when there's a patchwork of IP on genes and SNPs already in place. So do you guys have any comments on that issue? Is patent law going to have to change, or are there going to have to be changes in IP based on this that otherwise that are going to block a lot of this efforts that you're talking about?
But Jorge, you alluded to IP issues. Can you be a bit more specific about what you're coming up against?
Yeah, so look, I think it's a very good question, and that's clearly going to be an issue. So to answer your question up front, I think there's going to have to be some changes around how patents are dealt with in this space. I mean, there are a bunch of different models that have been proposed. Probably the simplest one was, an iTunes type model where you have a central clearinghouse where if you want to do an electronic version or a digital version of a test, you would pay a much lower cost than it would if you were doing the test one-off or you were licensing that test directly. But that's a question mark. We've spent a lot of time with our counsel and with outside counsel to make sure that what we're doing, it doesn't infringe IP. And what's interesting at looking at the IP landscape, at least as it currently stands today, is there's a big range of protection, from the very, very tight protection around things like the Myriad test to things that are very specific to biological analytes or an assay, a specific assay for a specific test. And so you have to work within that patchwork. We have the good fortune, obviously at the moment, since we're dealing with a relatively small number of individuals but looking at a lot of data, is that we can reach out to individual companies when we have a question or a concern. That's clearly not a scalable approach. So that's going to have to change.
Phil, did you have a comment? You are our resident lawyer, after all.
I really am not expert in IP law. I do know that there's been, talk about backlash, there's been a lot of backlash in patient communities when companies that have generated tests based on working closely with organizations of folks with a rare disorder have then charged a lot of money for the test. I actually have a different take on the IP. I don't think it's going to be a problem. I think it's going to be just overwhelmed by other forces in the society, and that it won't be cost beneficial to actually try and protect your freedom, your blocking patents.